Namaste, Dr. Ashwini. Uh,
Take it, Vijay.
in health question program, today is a very sensitive and very important topic we are going to discuss with Dr. Ashwini. All of us would have in past or recently experienced, there is a phase called anesthesia, whether it is general or local, but we want to run away from the pain. And that's the remedy through anesthesia given in this medical field, which comes as a blessing and a relief from the pain. But it has to be monitored by an expert, and it has its own technique and very detailed, I would say, knowledge which the expert has to have, so that the patient has a smooth time during surgery, post surgery, etc. So all that we will discuss with Dr. Ashwini today. So Ashwini, once again, Doctor, welcome to the program. And as I say, it is an educational discussion. So it is for the people like me who have absolutely no information or knowledge about medical industry and especially anesthesia. So first come first, Dr. Ashwini, what is anesthesia and when was it started before?
Thank you, Ketaki, for inviting me to this program, because anesthesia is a subject, it's an young subject actually in the medical field. And it started maybe around 150 or 170 years back, the proper anesthesia. In 1847, Morton started the anesthesia. In fact, he demonstrated the qualities of vapor, ether vapor, and he told in the Massachusetts hospital that it can give anesthesia. So that was the first discovery in 1847. And before 1847, people used to use some therapies like concussion, means they used to bombard the head with big stone, and that patient used to go into coma, and during that time they used to do surgery. So all these methods, it used to inflict lot of pain. Only thing is patient, he was not unaware, he was not aware of all those things. So, and later they started using some herbs, medicines, mandragora, mandrake, and all those things in Egyptians, especially in Chinese. And in 1847, when ether was demonstrated in the Boston, Massachusetts hospital, and from then the era of anesthesia started. And initially there was no anesthesiologist as such. So anesthesiologists were formed from a group of surgeons, physicians, and dentists who were in need of upturn of pain. So thus anesthesia, the subject started, and de novo anesthesiologists were not there before.
Okay, just deroute from the topic. In our Ayurvedic field, we have a Shushrut and we have a Charak Samhita, and we also heard that they also used to do the surgery. So, any idea what kind of anesthesia or some sort of precaution they used to do, or there was person has to go through the pain?
They used to use the herbal medicines.
Herbal medicines.
So, and it used to act as analgesia. And though it was not exact anesthesia, but patient never used to feel that much of pain. The pain used to be there. So they were using herbal medicines.
Herbal medicine. Okay. Okay. Now that we have come to the fundamentals, what is the scope of this subject when we say anesthesia?
Anesthesia is not much known to the public actually, because we recognize the surgeons, we recognize the gynecologists, we recognize orthopedician. So we are not frontline doctors actually. So we are the background doctors who work within the OT, operation theater, and behind the screen. So we are all behind the screen doctors, and most of the times we don't get much acknowledgement from the public, because we start with a small needle. You will have a pain of a small needle, and the patient becomes anesthetized. And later he will be in the ward, so hardly public knows about us. But this subject is highly evolving, because we have extended our care to the pain and palliative medicines. We have extended our care to the ICU. So we are working as intensivist
Mm.
and operation theater, as everybody knows. And we also extend our services to the basic life support. Means if anyone gets arrested, if anyone gets a heart attack in the layman's language, so the cardiac arrest. So we teach the paramedical persons, the medical persons, how to revive with the minimum equipments in that instant.
Yeah, okay, that was my next question actually. Where all you render your service? So
So
you,
we render our service in operation theaters.
yes, that's more important. Yes.
Yes. And we have also rendered our service, and we're still rendering our service to in intensive care unit.
Mm.
So now we have a branch called as critical care.
Mm.
So there we learn another 3 years of course in the critical care, and we become intensivist, where we deal with the critical cases like maybe the poisoning or hanging, or patients who is having burns and heart diseases, respiratory diseases. So patient who needs to be monitored on the ventilator. So all these things will be taken care of in the ICU.
Okay, now it is from your point of view, but from the patient point of view, those who are undergoing surgery or any kind of treatment, let's say, which is going to be painful, and for that the precaution is giving them that, I call it as a artificial insensitivity. Reason being, for some period don't have the sensitivity either in that area or the entire body, depending on the surgery.
Right.
Now, what are the prerequisites from the patient point of view?
So if a patient is posted for surgery next day,
Hmm.
so the previous day itself we examine the patient's from the history to the examination, and we include some investigations if needed. So patient should have good amount of blood, because patient should not be anemic, because he should sustain the surgery. So depending upon the duration of surgery and the severity of the surgery, we assess whether this patient can sustain it, and patient shouldn't have a respiratory tract infection, because most of the anesthesia we give it through the general anesthesia. We pass the tube through the trachea. So patient should not have any infection over there. Patient should not have any infection of the lungs. And if the patient is hypertensive, that means if the patient is having BP or diabetes mellitus, it should be under control. And if the patient can have other diseases also, it should be also under control. And we will also give an insight of what happens in the OT. So patient should know that all of a sudden something is happening, because patient will be very anxious. And talking to the patients for 5 to 10 minutes, most of the times it allay their anxiety. So preoperatively, though we give sedatives and though we give drugs, and talking to the patients and taking patients into the confidence is anesthesiologist's job, and it prepares him mentally for the operation theater.
Yes, yes.
And if required, we will get some investigations done like ECG, X-ray, and echocardiography if needed. And if the patient is not fit for surgery at that moment, and if the surgery can be postponed, most of the time surgeries cannot be postponed if emergency.
Yes.
So if it can be postponed, we will postpone the surgery. We will optimize the patient so that he becomes fit for the surgery. And if it is an emergency surgery, then we will take some time, we will buy some time, whichever is possible, and we'll optimize to an extent, and we will give.
Yeah, that is understood, because whatever best is possible is done in the.
It has to be done.
Correct. Now, while talking to you, I am visualizing nowadays with the technology, we are able to see some videos of anesthesia in the operation theater and those things. How the anesthesiologist is treating or taking care of the patient before the surgery and after that. So what I observed, Dr. Ashwini, is like, as you said, the thing goes through the mouth area and then inserted inside. Now, many times I also have spoken with mouth cancer oncologist and those people. Now, these diseases are where you need to insert your tube. How do you deal with these situations?
I'm very happy that you know all these things, because I consider you as a public, because to a non-medical person, and I'm very glad that you know that we have difficulty during those times.
Correct.
Most of the times, especially in North Karnataka part, we have this oral cancers. The incidence is quite high because they eat gudka chewers, pan chewers.
Chewing tobacco is a major challenge.
Yes. Incidence is quite high compared to the South Karnataka and other areas. And many times we feel difficulty while passing the tube because we will have very less space. But thanks to the technology and thanks to the gadgets, we have got fiber optic bronchoscopy where a thin tube which is having a fiber optic bundle. So we'll just pass the tube into the trachea with the minimum mouth opening. And once it enters into the trachea, we will pass the tube which was already been railroaded, and then we induce anesthesia.
Okay,
So
also
patients have to
Dr.
cooperate for this.
Yeah, just sorry to interrupt, but also another thing. People with a thick neck region, and especially when we say no chin or no neck for that matter, such people face more problem.
Yeah, absolutely. So they come under obese individuals. Okay, so one of the difficult area part is the neck circumference. We also examine the neck circumference. So depending upon that, there are special maneuvers in which we make the patient lay down. So we create an artificial pillow, and we see to it that patient's position is optimum for intubation, and we will keep all the difficult airway, that means difficult airway gadgets. So we have so many video laryngoscope. You just pass the laryngoscope and that video is seen on the screen. We have fiber optic bronchoscopy. So all those trolley we keep it ready in case if we don't pass the tube, and the last resort will be opening the trachea. Most of the times it doesn't go till then.
Doctor, it's been like 20 plus years you are here and
Yes.
treating the patients day and night.
Yes.
What is your experience with the kids? Because handling infants and kids is another challenge. So what about anesthesiologists faces about this part?
Actually, anesthetizing a kid is like anesthetizing a family. Because if one kid gets admitted and he is posted for surgery, the whole family is in the ward. So we have to convince the parents, we have to convince the grandparents sometimes, and convincing the child is a bit difficult because sometimes the babies may not understand.
Yes.
And even though they are very cooperative while talking, once they enter into the OT, they get apprehended with the environment. So most of the times, if the baby is very small, so we anesthetize in the mother's lap only.
Okay.
So we make mother hold her kid and in the lap, and there only we give anesthetic drugs. If the patient is having an IV line, we give anesthetic drugs in the mother's lap and then take the patient into the OT. If the baby is quite very small, if it is less than 28 days or something,
I would say,
then it will not have any stranger's anxiety. It's just like an small baby.
Correct.
So it's easy to do that.
Handling
but older children, maybe in high school or second PUC or somewhere like that, then either you convince the child. Sometimes they'll be very cooperative. They cooperate for the anesthesia, and sometimes we need to inject. वो क्या कहते हैं, थोड़ा कहानी वहानी सुना के हम उसको नींद की सुई देते हैं, और and then the things will become easy.
Yeah, got it. Doctor, another part which I personally want to understand is, as the role of a surgeon is important, so is the role of the anesthetist, because it has to be effective up to that period of surgery, and soon after the surgery, person should come out of that stage as per the pain tolerance level of the person, whatever in the medical term. How it is monitored and how crucial it is person to person, especially if it is a pregnant woman.
Yes. Pregnants will have their own complications. It's unique to them because of the pregnancy, there will be many changes in the body. She will be diabetic because of the pregnancy. She may become diabetic. and she may become
Hypertension,
hypertensive because
yes.
of the pregnancy.
Mm.
She can have some placenta related diseases, and anemia is also very common in
Okay.
pregnancy because she has to nurture the two lives,
Mm-hmm.
and so many other disorders can get exacerbated during pregnancy,
Okay.
and weight gain.
Ah.
So apart from this, even the weight gain can also
Yes.
be
Yes.
a bane for her.
Yes. Yes.
So patient can have convulsions
Mm.
because of the hypertension.
Mm.
And so if the patient is not referred in time
Mm.
the tertiary care center, or if the patient doesn't approach the doctor in time, then she can be in soup. So antenatal care is very important, and it also gives an idea for the gynecologist when to operate and what all and to deal with those patients. And regarding the monitoring, thanks to the gadgets, we have got excellent machines,
Yeah.
because most of the anesthesiologists, we are well versed with the physics, because we deal with the gases, we deal with the fluids,
Correct.
so gas laws and all those things. So our machines are quite automatic, and they are excellent in their evolution also. And we monitor blood pressure. We monitor pulse rate throughout the surgery. We do monitor saturation throughout the surgery, and we also monitor the temperature of the patient. Because with the long duration of surgeries, patient can become cold, hypothermic. So then it will be a problem to bring back the patient to the normalcy. So we also keep the warmers. So patient will be, sometimes we will be shivering, and patient will be under the warmer, because OT temperature in neurosurgery and all those things,
Yes,
they
really
keep
chilled.
around 21, 22.
Yes.
And for long time, we do feel shivering.
Correct, correct.
Yes,
True,
yes.
true, true. Doctor, the most common and very delicate, or we will say very vital surgery is the open heart surgery.
Yes.
And wherein the heart is put on the ventilator and then it's in the progress. What is your role and how difficult it is to manage that kind of situation?
So usually when they do in heart surgeries, once they do the closed surgeries, like through the femoral artery, the femoral vein, they pass the catheter, so angioplasty, they just require sedation at this time, and patient will be conscious. But during open heart surgeries, and it's very crucial, it needs expertise, and patient will be put on ventilator even after the surgery. And during the surgery, both the coordination between the surgeon and the anesthesiologist is very important, and both of them together deal with the diseases.
Yes. Doctor, which are scheduled surgeries and treatments, that is okay, perfectly managed, and it has its own routine. But there are some emergency cases, let's say an accident case or some sort of a burn case, which happens all of a sudden. So, such cases, when it comes to you, do you have any different treatment course for it?
Especially trauma cases, or maybe poisoning or hanging, whatever it is, or disasters. First of all, the system is not prepared well for the same. Sometimes we get mass casualties also. And even the anesthesiologist is not prepared well, and even the patients are not prepared well. They may be full stomach, because we usually tell the patient to starve the previous night so that the stomach is empty. And when we pass the tube, the stomach is totally empty. So, but in trauma cases, we don't know. Patient might have had food, and immediately he met with an accident while riding. So patient's stomach could be full. So we have to take care of that also when we give anesthesia.
I see.
So most of the times, if the time permits, we ask 8 hours to ensue so that the stomach gets emptied, and then we'll give anesthesia. Sometimes it is not possible. At that time, we take care of those things and we do anesthetize. And the bleeding. So in the elective cases, like in the scheduled cases, patient's HB will be very good. But here, you don't know how much he has lost. So we have to get investigated for that. So if he had lost too much of blood, then he may go into the coagulopathy disorders. So those things will also pose problem. Second thing, and third thing, if the patient has got head injury, most of the trauma cases, they will have head injury. So patient has to undergo CT scan because that is the first thing to be operated. It has to get first operated, and any next injuries. So all these injuries have to be ruled out, and then patient has to be anesthetized. So we have to do it everything in fast. We can't do it as we do it for scheduled surgeries. So we have to do everything in fast, and we have to take the patient for surgeries.
I think the more you are in this field and the more time you have spent here, that also must be playing a role while treating such cases because you have an experience with it.
Experience, obviously it matters because we most of the times experience will give you the knowledge how the course of this event will be. Most of the times, especially laryngospasm, especially if the baby is having upper respiratory tract infection, and usually parents, they lie to us. No, baby was fine, absolutely, and only you are telling like that. So sometimes we'll give in that hurry only, and most of the times we'll see to it that we don't anesthetize those cases. At that time, the baby is prone for complications, spasm and all. So all those things, it needs experience. So we will come to know with this drug, with this manuals, I think it will be all right. No, this child is fine, you shift to the ward. Young anesthesiologists, they take time, and they are also a bit apprehensive.
Correct.
Our experience, for that sake, it is very valuable and it's precious in all the fields.
All the fields. Definitely. Okay, we only know two names. One is local and one is general. Apart from there, is there anything? And what is the difference between these two also?
Yes. In general anesthesia, we anesthetize the whole body. Patient will lose the consciousness also, and his respirations, we usually control his respiration through the ventilators. So patient is totally relaxed. So with the history course, when the ether was introduced, so it was introduced as a vapor. It was in solution form. It was introduced in the vapor form. Later, many solutions came into the practice. And after that, to induce the vapor, to give the vapors to the body, many gadgets were invented. Especially the face mask. You might have seen the face mask. Now they are all evoluted face masks. So initially they used to do it with the red rubber face mask, which used to be very opaque. Now we have got silicone transparent mask. Even if the patient vomits or bites the tongue, we will come to know because it will be transparent. And after that, the tubes were invented, which used to get into the trachea. Yes. And for ventilation, bags were invented. Ventilators were invented. All these things were made of rubber. Okay. And from the rubber, now it has evolved into the silicone. Yes. And Amazon tribal people, they used to use cuirass at the tip of the arrows to paralyze the animals. That was taken, and we started using the cuirass. So the scoling, those things were used to paralyze the patients, especially in 1940 to Second World War. There was polio epidemic.
Okay. Yes.
So you might have seen those pictures.
Yes.
In the army camp.
Correct.
All those patients who were infected with the polio, they used to give ventilation, but relaxation was not given. And for better surgery, the muscle should be relaxed. So for that, we started giving relaxation. And after that, once everything is relaxed, we took over the control of respiration. And we took the control of blood pressure. Yes. And later came the regional anesthesia. So local anesthesia is different. For example, if the tip of the finger has got some
Okay.
abscess,
Yeah.
you just give anesthesia over there and you'll get rid of those abscesses.
Mm.
But regional anesthesia means we anesthetize a group of nerves.
Tissues. Okay.
For example, if it is the upper limb,
Mm.
we anesthetize the group of nerves called as brachial plexus.
Okay.
To
operate the shoulder region.
Yes, yes, in the neck region.
Mm.
And the whole only that upper limb will be anesthetized. Patient will be conscious and talking to us.
But that region will be insensitive.
Only that region. That's called as regional anesthesia.
Oh, so
For example,
especially when we
severe
go to the dentist, they make this particular.
Yes, that is local anesthesia.
Local anesthesia.
That is local anesthesia.
Mm.
And for inguinal surgeries or hernia surgeries or some cesarean section, any surgeries over the lower limb, lower abdomen, we give regional anesthesia. That means we give anesthesia to the spinal cord. We inject the drug to the spinal cord in the layman's language. Sorry, to this intrathecal space.
Yeah.
And the area below which gets anesthetized. And now we have we are giving regional anesthesia even for the breast surgeries, and we are giving regional anesthesia for thyroid surgeries, at least for the analgesia purpose. And so many blocks also we are giving. So we are identifying the nerve groups between the two muscles through the ultrasonography, and we are injecting the drugs, and patient will be pain-free for the another 24 to 48 hours.
Correct.
Yes.
I think that is much more smarter than making the entire body insensitive. Only that particular region is.
Yes. Yes.
Yeah, I think that makes more sense.
And it also needs expertise.
Of course.
Yes.
Of course. Of course.
And general anesthesia is a type of stress actually. So if you can avoid general anesthesia, that's well and good.
Last but not the least, what it needs to become anesthesiologist?
Yes, actually, when I took anesthesiology as a subject of my post-graduation, even my parents didn't know that subject existed. So they were thinking and they were asking me, what are you going to do?
Doing this.
Because so there are so many subjects like that. If you come from a middle class family and who are not aware of the medical field subjects, then we do experience these type of questions. So after the MBBS degree of 5.5 years, 4.5 years plus 7 years of internship,
Okay.
Once again we take the entrance, and once we qualify in the entrance, we go for post-graduation in the subject of anesthesiology for 3 years. So that's a postgraduate degree. And now this subject has evolved into many more subspecialties: cardiac anesthesia, neuroanesthesia, pediatric anesthesia, and obstetric anesthesia, and pain and palliative care, which is now it is taken over by the anesthesiologist, because most of the patients, especially cancer patients, for whom surgery cannot be advised, but they have to undergo pain. So in those patients, we do give some blocks and make their life sustainable, make their life pain-free during their last days of life. So pain and palliative, especially we have got many hospitals like hospice. We call it as hospice. So it is taken care by anesthesiologist, and we do have subspecialty in critical care. So it's another course of 3 years. So total it will be around 10 years.
10 years.
Yes.
Right. That's a long period.
Yeah, it's a long period.
Absolutely. Actually, what is the role in pain and palliative care? Just now you mentioned.
Pain and palliative care, for example, a patient, if he is having some pancreatitis, okay, he will have intolerable pain. So we inject the alcohol, absolute alcohol. Initially, we inject the local anesthetics to those nerve groups, and patient will be free of pain. And if the disease cannot be improved, at least we can make him pain-free. So we will totally ablate those nerves by using absolute alcohol and so many other drugs. So totally he will be pain-free. The same thing will happen with the oncology, tumor cases.
Mm.
So some tumors cannot be operated.
Mm.
They would have gone to the last stage. So
Mhm.
only thing is palliation.
Yes.
So make their lives pain free.
Free.
They do come to the pain and palliative care clinic,
Mm.
and where we give some of the blocks, neural blocks. It will affect the nerves which is supplying the tumor and causing the pain. And totally the patient will be pain free if we destroy those nerves.
One final question. Bharat as a nation, are we fully equipped in anesthesia or we are still taking something from outside?
Actually, the type of anesthesia which we are giving here is almost in par with the Western. Okay. The only thing is the number of anesthesiologists have to increase.
Okay.
Because yes, the ratio of population to the doctor is still low. When
Supply demand issue is
WHO, as per the WHO, we are still insufficient for them. So in the doctors group, we have anesthesiologist group also. So many more anesthesiologists will make a lot of difference in the society.
Yes.
And the good care will be given even at the periphery, because most of the village people will come to the tertiary care center, to the nursing homes which are situated in the cities.
Yes.
And staying in the cities for a week will be really trouble for the villages people. So more doctors, not only anesthesiologists, more surgeons, more doctors, they can move to the periphery, and they can make a heaven for the villages there.
At least occasionally they can visit, if not permanently. And
Yeah, people are doing it right now,
yeah,
because
there are many who are doing it.
Saturday, yeah, every Saturday, Sunday, they
Yes,
go to
yes.
the peripheral part, they
Yes.
do operate some surgeries and they come back. But the continuous and emergency, which will not be done over there around the clock.
Great. It was nice talking to you, and we just hope and pray that more experts like you are there in the medical field, so the life of the patients is pain-free and smooth, pre and post surgery. Thanks. It was wonderful talking to you.
Thank you, Ketki, because I use all the opportunity to make the public aware of my subject.
Yes. Yes.
So it was an excellent opportunity for me, and it was nice talking to you, and I'm very glad that you know most of my subject, and I want the public to be like you, so that they cooperate whenever they come for the surgery, and they understand us,
Yes.
and we are for their betterment. And
That's
we
the
are
whole purpose. Health quotient we want to increase in people. Everyone need not go to the doctor without much awareness or knowledge. We are not saying that you should overpower doctors, but what we are saying is, as long as we can take your own care and take precautions and delay the visits to the medical field, that will be easy for you and as well as to the doctor fraternity. Thank you so much.
thank you.
Namaste.
Namaste.